You're listening to the Innovation in Healthcare podcast, produced by Health Innovation Northeast and North Cumbria, proudly improving health and care for everyone. IBEX is a bone health company, specialising in early detection of osteoporosis. The company has received support from both Health Innovation Northeast and North Cumbria and Health Innovation Network South London as part of South London's FemTech Accelerator. In this episode, our programme manager Ian Taylor leads a discussion with IBEX Chief Executive Dr. Paul Scott and Chief Medical Advisor and Broadcaster Dr. Sarah Jarvis on the importance of early screening for osteoporosis, a condition which Sarah herself has been diagnosed.
Hello everybody, my name is Ian Taylor. I'm one of the business coaches and have been working with the Health Innovation team in North Cumbria for a number of years now. Back in 2023, with funding from Innovate UK and as part of the Biomedical Catalyst, which was run in collaboration with the Medical Research Council, there was a launch of the first national FemTech Accelerator, and this was run by the South London Health Innovation Network with some assistance from members from the other health innovation teams around the country. The programme was to look at and develop early stage companies with a focus purely around women's health. IBEX Innovations were part of the first cohort and received coaching from myself and a number of other people within the accelerator. This was within a 10-week program of workshops and mentoring to aid IBEX Innovations to move forward and bring their innovation closer to the market deployment. This is all part of the long-term NHS plan, where one of the three key shifts is to move from sickness to prevention, and in doing so alleviate a lot of the pressures that are being felt within the NHS. One of those is around osteoporosis, which affects a large portion of the population as they age. I'd like to introduce Paul Scott, CEO of IBEX Innovations, and Dr. Sarah Jarvis, who's part of their medical team.
Hi Ian, thank you for the introduction, and delighted to be here to talk about our experiences on the Accelerator program and also about osteoporosis and IBEX bone health and how we're using that to solve the underdiagnosis problem.
Hi Sarah, would you like to go forward?
Absolutely. Thanks very much indeed. Well, it's a pleasure to be with you. It's really interesting that we're talking about this in the context of FemTech, because actually osteoporosis does affect men as well as women. The difference is that it affects far more women than it affects men. And I think that's the real key here. It is very much a woman's health problem in that respect. Between 1 in 2 and 1 in 3 women over 50, along with 1 in 5 men, are going to break a bone because of osteoporosis. That's probably about 500,000 broken bones every year in the UK. And that is a huge cost to our NHS and our economy, about £4.5 billion. In fact, to put it into perspective, these breaks are kind of the 4th worst cause of disability in premature death in the UK, and they're the 2nd biggest filler of hospital beds. Now, I've got a professional interest. Obviously, I've been a GP for a very long time, for 35 years, but I've also been diagnosed myself before I had a fracture, more of that later, with severe osteoporosis. So I became an ambassador for the Royal Osteoporosis Society, and I was delighted to join IBEX Bone Health as their chief clinical advisor after I did my due diligence and became absolutely convinced by the work they were doing.
Great, thank you, Sarah. That's really interesting. You brought in there about osteoporosis affecting both men and women, but more likely to be affecting women, and the impact not only on the NHS, but also the economic impact for that individual and the time off work as well. Why do you think it's so important? People talk about cardiovascular disease and osteoporosis. What's the difference between the two?
Well, basically, cardiovascular disease is another major factor, and we know that costs about £7.4 billion a year. But we've seen that we have dramatically reduced the number of people dying from and indeed living with cardiovascular disease over the last generation or so, I suppose. About 20 years ago, the UK government decided they were going to target 2 risk factors for cardiovascular disease, 2 of the biggest ones: raised cholesterol, raised blood pressure. They were not going to wait for people to have a heart attack first. And that was really important because, of course, many people will die when they have their first heart attack, and many people will be left disabled because they'll develop heart failure and so on. Now, what we've seen more recently is that we've been able to leverage the improvements that we've seen in treatments for cardiovascular disease, or to treat those cardiovascular risk factors. And we've been able to, again, reduce, in fact, more than half the death rates from cardiovascular disease over less than a single generation. Now, if we put that into comparison with osteoporosis, there are lots of similarities. Osteoporosis is really common. It's really expensive, as I've said. It's the second highest cause of unscheduled hospital admissions. And we've got thousands of people dying from it, businesses losing about 1.5 million workdays every year as a result of osteoporosis fractures. So unfortunately, that's kind of where the similarities end in terms of what we've done about it, because we know that there are lifestyle treatments, lifestyle recommendations that can make a big difference to your risk. We know that there are drugs which have a very, very low acquisition cost, about £2.20 a month, that can really reduce your risk of having an osteoporosis related fracture. But if you think about it, would you be utterly horrified, because I know I would, if somebody, for instance, went into hospital with a heart attack and was sent out without being checked to see whether treatment might reduce their risk of a further heart attack? Of course you would. Nobody would dream of that. And yet, actually, we do have something called fracture liaison services who are supposed to pick up people who've had a fracture, because that greatly increases your risk of having another fracture, assess them and determine whether or not they need treatment, and if so, what treatment they need. But 2 in 5 trusts in the country don't even offer this after you've already had a break. And there is no national screening program for it, which means that there is no consistent way of identifying people at high or even very high risk of a fracture and stopping them from having that fracture in the first place. 1 in 5 people who have osteoporosis are going to break 3 or more bones before they ever have a diagnosis and before they can receive treatment that might reduce their risk of further fractures.
That's quite compelling, that we need to be doing something about this, and the impact both on the individual and their families. Because, I mean, breaking the hip bone, for example, can take months to recover. If you actually do fully recover, it's amazing.
I couldn't agree more. I mean, the figures on that are really scary. You know, the National Screening Programme has admitted that half of people who have a hip fracture are never going to live independently again. Some estimates suggest it could be up to 3 in 4 people who previously lived independently who will never be independent again. And up to 1 in 5 people who has a hip fracture dies within the next year. We don't think of osteoporosis as being something that kills you, but it robs you of your independence, and it can be fatal. And about half of those hip fractures are in people who have never had a fracture before. And osteoporosis doesn't cause any symptoms until it causes you to have a fracture from a really, really minor fall. You know, you could trip over the cat, you could cough or sneeze and break a rib, you could bend over and your spine could partially collapse.
So talking around the osteoporosis and the prevention element that we're looking at, what is the IBEX Bone Health product, and what does it do around that? And that question's through to Paul.
Maybe it's useful, first of all, talk about the changes that occur in the bones as a result of osteoporosis. So osteoporosis is results in a thinning of the bones and a reduction in the bone density and the strength of that bone. And with just a 10% reduction in bone density, the risk of a hip fracture actually increases by 2.5 times. We at IBEX have developed software called IBEX Bone Health that actually measures the density of the bone, and it also makes a comparison of that bone density to a normal healthy patient. That's a recognized clinical measure, which is called a T-score. So it measures how far you are away from a normal healthy patient in terms of your bone density. What this allows us to do is we can very accurately predict from a measurement of the wrist the likelihood of a patient having osteoporosis at the hip or the spine. And we can then use that as a means to make much more accurate referrals into DEXA, which is the standard diagnostic test for osteoporosis. The challenge today with DEXA is it's a very specialist technique. It requires special operators, a special piece of equipment and space in the hospital to provide that. Consequently, it's very expensive and relatively scarce in the UK, with just around about 7.5 DEXA systems per million head of the population. So that really creates a bottleneck in terms of bringing patients through. So really what you want to do is to limit the use of DEXA to those at greatest need and shield DEXA from those who are unlikely to benefit from a scan and treatment. And IBEX does exactly that. So it performs a very accurate measurement of the bone density of the wrist, which is then used as a means of predicting the likelihood of someone benefiting from a DEXA scan and treatment. The other side of it is the sort of clinical vigilance side. So as much as we know that from the NICE guidelines, women over 65 should receive a bone health assessment, and men over the age of 70, and also anyone who has risk factors associated with osteoporosis. We know that in practice, the NHS is really overstretched and doesn't always happen. That's not always the case. So that really, as Sarah mentioned, osteoporosis is a silent disease, and that really puts a huge burden on the clinicians to remain vigilant to identify patients who are likely to be at risk. And that's the other area where IBEX comes in, is that our software is always on. So it's always assessing wrist x-rays that come through, and it's able to flag those at risk automatically to the radiologist. So that really unburdens the clinician from the worry, and it provides an extra layer of scrutiny on the patients who are coming through. We've shown this to be effective in X-ray and in mammography, and we're now working towards bringing this in as a means of really improving that referral from someone presenting with this silent disease into more efficiently into DEXA and onto treatment.
And I think it's really important that we talk about this idea of screening. Basically by waiting till somebody's had a fracture, we are waiting for failure, effectively. As Paul says, women over 65, men over 75 rather than over 70, we should be considering all of them for assessment of their risk, and anyone who is under 65 and who has other risk factors, particularly women, for instance, over the age of 50, who've got another risk factor. And there are lots of risk factors. It could be there's a family history of risk factor. It could be that they've got a low body mass index. In other words, they're underweight, or they have been underweight in the past. They went through the menopause prematurely. They smoke. They drink excess alcohol. They've got conditions like rheumatoid arthritis or diabetes. There are so many things that can increase your risk of osteoporosis. Some of them we tend to think about. So if somebody's taking regular oral steroid tablets, people do tend to, think osteoporosis, but many of them actually are minor conditions on their own. But we're more worried with if you smoke, we're worried about your lungs, we're worried about your heart, but all too often people don't worry about osteoporosis, and GPs have got so much on that it's almost impossible. The great thing about IBEX is that, as Paul says, it's always on, and that means that the overworked staff, because we know everybody's overworked, including everyone in the radiology department and all the radiographers as well as GPs, it means that it's always there, and it's effectively doing those assessments for you.
That's great. I mean, you talked about use in the mammography area, and part of this being prevention. Are you looking to include that within when a lady presents for her general assessment on the annual, every 3 years or 5 years, however often that is, so that you can actually start catching way ahead of when they're going to have a break, so that you can do interventions. Is that way you're looking to really drive that forward towards?
That is precisely my dream. You've basically got it in one. So we can divide prevention into primary prevention, which is stopping something happening in the first place, and secondary prevention, where you pick up somebody who, in this case, has had a fracture, and you reduce their risk of having another fracture by treating them. So with primary prevention, what we need to do with any screening is we're supposed to look at people who are, quote, high risk, accepted by society or by the statistics as being at high risk. Well, we know that that is postmenopausal women. Again, I go back to that figure. Half of the hip fractures we see are among postmenopausal women who have not already been identified as having osteoporosis. We know that the older you are, the higher that risk is. Now, breast screening, of course, happens routinely from the age of 50 to 70. You can continue to ask for it thereafter, but for most women, it's in the 3 years after you turn 50. Now, what we could do, it would be so easy to do, because we're using mammograms, so we've already got the X-ray machinery available in every breast screening service in the country. We do not have DEXAs. You know, we've heard from Paul that we've got one of the lowest rates in Europe of DEXA scans. We've only got 7.5 DEXA scanning machines per million people, and it's not just the machines; it's the people, the specialist operators who need to work them. Whereas with mammography, you've got people who are going in, you've got a machine that you can use, and at the same time, the same machine could be used just to provide a simple X-ray. For instance, what we could do is we could start small. We could say, okay, when you turn 65, we will ask you to fill in a form, and it's a self-completion form, and it looks at all those risk factors. Do you have any of those other risk factors? And people can fill in basically their own forms about, you know, whether they smoke, whether they've got a family history of risk factor, when they went through the menopause, all that sort of thing. And then that could be simply applied to provide what's called the FRAX score, and that's part of your risk of breaking a bone as a result of osteoporosis. You can then do the IBEX bone density score. That will provide you with something which will allow us to say, okay, you are at low risk. We don't need to worry too much about you. You are in the middle, so perhaps talk to your GP about lifestyle advice and so on. But most importantly, the ones we really want to identify are those who are at really high risk. And again, I consider myself incredibly lucky. I went into my GP and said, I think I might need to have a bone scan because I've got some risk factors. They're not obvious risk factors, but I'm a doctor. I know what the risk factors are. And my GP was fantastic, sent me off for a bone scan. Lo and behold, so I didn't just have osteoporosis, I had severe osteoporosis. And to put that into perspective, basically where Paul mentioned the T-score, what we're doing is we're comparing your bone density with a young healthy person. And a figure down as far as minus 1.5, so 1.5 standard deviations. Forget the standard deviations, it's the figures down to a score of minus 1.5. That means that your bone density is normal. If it's between minus 1.5 and minus 2.5, you have what we call osteopenia. That's thinning of the bones. Your risk is higher. You've got a higher risk than other people, but it's not really high. You haven't got full-blown, if you like, osteoporosis. If it's less than minus 2.5, then you have osteoporosis. By the time you get to minus 3, we're talking really usually severe osteoporosis. My figure was minus 4.1, and I would never have been picked up had it not been for having that DEXA scan. But the point is that if I'd gone in to have an X-ray for another reason, I have had a couple of X-rays recently, that could have flagged me if I wasn't a doctor who had gone in and asked. And in fact, we're actually doing a pilot with Royal Cornwall's Hospital Trust and have identified at least 2 patients who are very, very similar to me, similar age, so they wouldn't have been flagged as being at high risk, no obvious risk factors, hadn't had a fracture, but as a result of getting this IBEX done, they have been identified as being at very high risk, and they've been able to get on to really effective treatment before they broke a bone. So it may well have prevented them living in misery or possibly losing their independence or even losing their life.
Yeah, it's quite shocking. I mean, to my mind and my understanding of osteoporosis myself is that as a lady ages, and we'll just talk about the women in the room here, when you go into your perimenopause and then menopause and then postmenopause, your bone density acceleration on how that's going to be affected due to your hormone changes.
Yep.
It just accelerates.
Yep. That's exactly right. So that drop off, as your estrogen in particular drops, then the density of your bones, that natural decline in bone density, which affects all of us from probably our mid-30s, just absolutely takes off. Now, interestingly, if we look, the UK National Screening Committee did look at osteoporosis, whether there should be a programme. Last looked in 2019, and at the time they said, no, we don't recommend a national screening programme. But some of the things they were looking at, for instance, were the fact that there aren't enough DEXA scans. Well, you know what? If you've got an alternative that means you don't need DEXA scans, then that all of a sudden that becomes largely irrelevant, because you can identify people who might otherwise have needed one who won't need one now, and you're tailoring it so that the people who really do need it are the ones who get one. Likewise, we've just incorporated in the last month questions about menopause into the national NHS screening programme, which is available to everyone from age 40 to 75. Now, any woman who goes through the menopause is going to be a woman who is at higher risk of osteoporosis. Therefore, if we could just incorporate those questions into that and maybe refer those women for a standard X-ray rather than having to refer them for a DEXA scan, of which there simply aren't enough. I mean, we know that 2 in 3 people wait more than 3 months for a DEXA scan, and of course we've got a lot more people coming down the line who are going to need them, because more and more women, for instance with breast cancer, are taking drugs called aromatase inhibitors, which are great at reducing your risk of recurrence of breast cancer, but not so good for your bones. And the recommendation is all of those should be having a DEXA scan. So, you know, there are lots of strains and stresses on the current provision, but if we can find an alternative which would allow us to say, that patient doesn't need a DEXA scan, that patient does, then we can actually improve that. We can work more smartly in terms of determining who needs DEXAs.
That then starts looking at other areas of the national health agenda, which relates to health inequalities. I would imagine that there's an issue, or is there an issue around osteoporosis within that as well?
Oh, yes, absolutely. So huge inequality based on deprivation in terms of osteoporosis, because we've got a double whammy here. Firstly, the more deprived the area you come from, the more likely you are to have osteoporosis and have osteoporosis-related fractures. So, for instance, in areas of deprivation, you're more likely to smoke, you're more likely to have COPD, which means you need to take steroids, you're more likely to have a poor diet with low calcium, low vitamin D, you're more likely to have low levels of exercise, which are really important, weight-bearing exercise for reducing your risk of osteoporosis. You're more likely to have diabetes, type 2 diabetes, which is a major risk for osteoporosis. So you're more likely to have it, and yet you are less likely to get HRT, which can protect against osteoporosis, and you're less likely to get targeted osteoporosis treatments.
How is the system currently finding women with osteoporosis, the high-risk ones, and is that through related fractures, or is that?
Well, Paul, I think it's fair to say the answer is they're not finding them, are they?
Exactly. So I think, as Sarah mentioned earlier, we operate a system of secondary prevention, which Sarah just described as waiting for failure. Essentially, the patient fractures first, and it is a postcode lottery in terms of whether the hospital has a fracture liaison service who will find that patient and get them into the necessary assessments. But today, it's woefully inadequate. And coming back to the point on the screening program, I think we would all like to see a national screening program for osteoporosis. I think there's a good justification to look at this again, but I think if you look at the barriers to that today, it's largely around the infrastructure. The costs are just prohibitive. So we've talked about lack of DEXA, lack of operators for DEXA, prescribing, etc. And really, this is where we come in, is that we're looking to harness the existing equipment. So we've talked about mammography and X-ray, much more widely available. But also, most importantly, it's the appointment and the whole service around it. So if a woman's already attending for a mammogram, why not at the same time take a quick X-ray of the wrist on the same equipment and determine her bone health? It makes a lot of sense. And actually, I think a joint bone and breast screening program, bringing the two together, makes a lot more sense than looking at two independent programs. Rather than going for a day one implementation across the whole population, what you do is you target the most at-risk patient groups first, and you work your way down through the patient groups. So women are by far the greatest risk. So why not harness that mammography screening appointment? But also the acute need, really, as Sarah mentioned, is in those patients who are receiving aromatase inhibitor treatment, which can be detrimental to bone health. So there's an opportunity to start small and to build out. The addition to existing services, I think, is the way forward.
Yeah, I think it totally plays towards the making every contact count. So if somebody's presenting or going in for one thing, they've already committed their time, their effort, and their travel time. So if you already have the staff there and the equipment, it's utilising that time in far more efficient manner. And then you can talk about health, lifestyle changes to somebody who's on the curve but is at low risk. So around the high risk factors and osteoporosis, who are you most wanting to identify during all of this process?
Well, we want to identify the women who are most likely to benefit, and those are the ones who are at highest risk of having an osteoporosis-related fracture. Now, if you look at the National Osteoporosis Guidelines Group, the NOG, what they say is that women whose risk is 60% higher than the threshold at which we would normally intervene are the highest risk people. Now, it's difficult because on the basis of your other risk factors, there isn't an absolute T-score that correlates with that. But on the whole, if you think that minus 2.5 or less is osteoporosis, minus 3 is usually more severe osteoporosis, those women with a risk of a T-score of minus 3 or lower are likely to be the ones who are at highest risk. Now, those are the ones we most want to target because they're where we get, if you like, the biggest bangs for our bucks. They're the women who are most likely to have a fracture and who, according to NICE, with their recent recommendations on the new osteoanabolics, would be eligible for treatment with these drugs, which really do help to rebuild bone. So bone is constantly shifting. There's a constant process of it being built and it being resorbed, in other words, taken back into the body. It doesn't just sit there. It's a living matrix. And so we have two ways of dealing with osteoporosis. Obviously we have lifestyle, but in terms of drugs, we have what we call anti-resorptive drugs, which are the standard drugs, which are very low acquisition cost, £2 a month, and really can make a difference because they slow down bone loss. But for people with more severe osteoporosis, we've got these so-called osteoanabolics, which are actively helping to build back up the bone. And in particular, I think the spine, because unfortunately, fractured spines are a terrible, terrible cause of chronic pain. So we take those women first, and we're looking for a relatively small number of very high risk women, and that doesn't increase the workload. But the thing about IBEX, as Paul I'm sure will tell you, is that you can actually set the threshold for wherever you want, and you can change the threshold as it beds in and as healthcare professionals realise they're not going to be swamped. Is that fair, Paul?
Absolutely. So so the software provides the same biomarkers for osteoporosis as DEXA. So as we've said, bone mineral density and T-score. So really it's up to the local hospital to make a decision in terms of where they set that threshold, refer versus don't refer. I think to some extent that'll depend on the service provision within the hospital. If you have a hospital where there's plenty of access to the downstream services, then obviously you can lower that threshold and see more people. But where services are much more constrained, you maybe only want to see those at the very highest risk. So our recommendation is to go for a T-score of -3, and the rationale for that is that a patient who has a wrist T-score of -3 or less has the same fracture risk as a patient who is already fractured. So because we know that there are fracture liaison services there who treat a fracture as a really strong risk factor for osteoporosis and regard that as an event that is worth taking action on. We've essentially set our guidance around that as a risk level. So if the patient has T-score of -3 or less, essentially they're no different to a patient who is in front of you with a fracture in terms of their risk profile. And actually that creates a really, really nice kind of level playing field against FLS, which is looking for patients with a fracture. And essentially we've demonstrated just that with the Royal Cornwall trial, where they're using that as a threshold and they're seeing patients with fracture and without fracture. So it seems to be working well. Obviously that threshold could change over time as services improve, but that seems a very, very solid place to start.
Will this also help the fracture liaison service in general, because you're identifying and therefore triaging and risk assessing all of the people that will be coming through rather than them having to crawl through?
So we provide a report to the reporting radiographer or the radiologist that deliberately has all of the clinical information, the T-score and ABMD, but also a very clear understandable message in terms of what is the next action. So removes all of the ambiguity from the process. So this can be used by fracture liaison service to identify patients, but similarly those without a fracture, it can really speed up that process. So absolutely, I think it has value on both sides of the fence, I would say.
Coming back to the FemTech Accelerator, which when we started talking a couple of years ago, what difference has that made for IBEX and how's that helped you?
So I think the FemTech Accelerator really sharpened our focus on women's health as opposed to, so osteoporosis affects everyone, but actually the problem is most acute in women's health. So we got place on the first intake for the FemTech Accelerator program, and Ian was our mentor and did a brilliant job, I have to say. That really helped us to identify our value proposition, sharpen that up, but also how to interact with the NHS. And Ian, I know you are a big believer in the technology and in IBEX. I think having someone in your corner when going into those sort of discussions is really, really important. As a result of that, and I think this was a brilliant part of the Accelerator program, there was some ring fence funding from the biomedical catalyst, which was you still had to apply for it and be awarded it, but it was ring fence for those who had successfully completed the FemTech program. So we put a grant application together for a small amount of money to run a very sort of limited pilot to essentially evidence that the software could be put into use within the mammography setting without disrupting the workflow in mammography screening. The appointment time is critical, so you have a lot of patients to get through, and you can't extend the appointment time by adding more measurements to the appointment. So we did a 15-patient study looking at one, could this be delivered within the appointment window, and two, what was the clinician and patient view of this additional service. And I'm pleased to say the patient feedback was really positive. The pilot was actually oversubscribed because of the number of women who wanted to get onto the pilot. We actually limited this to patients who were going on to aromatase inhibitor treatment, and they received a wrist X-ray using the IBEX Bone Health software on the mammography equipment itself, and then a follow-up DEXA scan to assess it following that. Really positive feedback from patients and clinicians, and also it was shown that we could deliver this with only about a 1 to 2 minute addition on the overall appointment time, which I'm confident will come down to effectively zero once the staff get trained in doing this, and it becomes kind of part of the normal routine. So it was really positive findings. We also looked at what the sort of cost benefit analysis in terms of dose to patients is, because x-rays are obviously potentially harmful, so there's always a risk benefit assessment to be done there. And the calculations that Adam Brooks did showed that it was around about 1,000th of the dose of a normal mammogram, and was equivalent to eating around about 6 bananas, so really inconsequential in terms of dose, and the benefits obviously of identifying a patient are really huge. So following on from that, we've worked with our local health innovation network, so Health Innovation Network Northeastern Cumbria. We were invited to the Women's Health Summit that was run in Gateshead. I think that was 2023. That was a really useful networking event for meeting other people in this area. And we also won the Bright Ideas in Health Awards last year for the use in mammography, which was amazing, and really helped to build the profile of IBEX, particularly amongst investors and the like. So yeah, really helpful.
No, that's great. I mean, your product really was filling a need area where there's limited capacity, and the outcome of what you are assessing is massively impactful, bearing in mind that 51% of the population are women. All of them are going to be going through this journey at some stage, and some potential element and risk. It's a huge shift, and being able to do it as part of an ongoing screening, because all women have heard you need to go for a breast screening, so to incorporate it in that and alleviate another pressure point for women is just enormous. How are you looking to take this forward, and what's going to be the next steps?
I would say that the technical proof is there now, so we have no doubts over the data. We have lots of publications out now on the technical performance. We also did a healthcare economics study earlier this year, which was published, that showed that screening for bone health opportunistically, so this was through the X-ray route, is cost saving to the NHS and delivers huge socioeconomic benefits. So the figure was around about 66 million cost saving per year by implementing this, and around about 240 million in socioeconomic benefit from the software. We've demonstrated its equivalency to DEXA, so non-inferiority to DEXA when using the same reference site. So when measuring wrist on IBEX Bone Health versus wrist in DEXA. So the question now is not a technical one, it's more of an implementation question about how does this fit into the pathway, and how does this influence outcome for patients. So the two studies that we've talked about, so we talked about the Adam Brooks trial. We're also working with Royal Cornwall, who are using this for primary prevention, which is a really positive step. So actually patients who have a fracture will be picked up by their fracture liaison service, but that leaves a whole host of patients who haven't yet fractured vulnerable to osteoporosis. So we're running a pilot there where we're picking up patients at high risk and they haven't fractured yet. We're seeing those patients moving through into treatment now, so we're actually preventing them from hopefully ever having a fracture. That's been shown to be sort of integrated seamlessly into the workflow, but really we need to build out more evidence through more of those pilots to really evidence the impact. So that'll continue. We're hoping to build more pilots and actually extend the mammography study into larger patient numbers in the next year. We're also commercializing the software. So we we provide the software to the X-ray and mammography system manufacturers, and it integrates into the hardware itself. So it can be run kind of seamlessly behind the scenes at the point of care. So we have two suppliers now. So Agfa Radiology, who launched the product last year, we're hoping to be into first sales of the product in 2026, and Metaltronica, who are a mammography system manufacturer. So working with our partners, we are hoping to start seeing this going really into the NHS and wider in serious volume over the next few years. So that's kind of the here and now. I'd say just a bit of a look to the future as well, where we're going next. So we just published some findings in partnership with the University of Exeter, showing that this can be extended to other body parts. So the next one is the knee. So by adding more body parts, you obviously can capture more patients. And we have a further extension to the ankle as well, which will follow. The next step beyond that is measurement at the hip. So the reason that's of interest is that the definition of osteoporosis is a T-score of less than -2.5 as measured at the hip. So as a result of that, making a direct measurement at the hip rather than an inference of the likely problem at the hip is seen as really valuable. So we are developing that now, and we hope to be able to, in the next couple of years, we'll be releasing a diagnostic version of the product. And really our aim in everything we do is to use every X-ray as an opportunity to diagnose osteoporosis.
Sarah, did you want to add anything around that?
No, I couldn't agree more. I just think it's so important. It's been the silent epidemic for too long, and we've waited for failure for too long. You know, we now have the tools, we've got technology, which means really importantly that we don't need whole new systems set up. We don't need women to have to come in more frequently. We don't need people with new skills to, don't need to train up people to use DEXAs, because we can now use those DEXAs more smartly by incorporating this sort of system.
Yeah, absolutely. I mean, the impact on the whole system, the NHS and the people, is going to be quite substantial once this is rolled out across the country, and hopefully that's going to happen sooner rather than later. Thank you very much for your time. It's been most informative.
You have been listening to the Innovation in Healthcare podcast, produced by Health Innovation Northeast and North Cumbria. If you'd like to find out more about IBEX and their work in osteoporosis, you can visit their website at ibexinnovations.co.uk. You can also learn more about our support of women's health and FemTech innovations on our website at healthinnovationnenc.org.uk. We will, of course, provide further links and resources in the podcast show notes. Thank you again for listening.